Good evening, everyone. Thanks for joining us tonight for our very first Middle East dedicated ANTEC webinar session. So I'm Dr. Myriam Barange-Ete, the Senior Director of Operations for ANTEC Laboratories. And so we are thrilled to partner with our colleagues at St. Vincent Group to bring you all the diagnostic supports you may wish for in order to be able to provide the best level of care as always to your patients. So today, thanks to SVG team, you indeed will be able to access the ANTEC Global Ref Lab services, in-house diagnostic services, and telerad services with the new AI solutions, this in UAE. So we're here to help and act as an extension of your clinical team, basically, so that you can spend most time with your patient and owners, while we support you with all your diagnostic needs and bring you the best turnaround times. So as part of this new service, we wanted to introduce tonight and bring the second session on December 5, the ANTEC histopathology service. So with our team of board-certified histopathologists and consultants, we can provide 7 days a week support, and our turnaround times for histo is usually 3 to 4 days. So at ANTEC, you can have access to the specialty groups. So the best expert in the field basically can read your samples based on their nature of samples. So we've got dermatopathology group, liver group, renal groups, exotic groups, etc. And something we're also very proud to bring and to have available is to bring you the consultancy support, basically free of charge. This means the service doesn't stop at the pathology report, but you can also access oncology, for example, specialty consultation afterwards, or internal medicines consultations to discuss the case with other specialists. So this has been a game changer for us in Asia. I'm actually based in Hong Kong, but very looking forward to actually have you also enjoy this service and obviously, hopefully, love it in your part of the world. So today, to introduce our histopathology service, let me bring you and introduce you and welcome together with you Professor Matty Cooper. So Dr. Cooper is actually based in the US right now, so it's very international tonight, and he's a board-certified veterinary anatomic pathologist with extensive experience in tumor and molecular pathology. He's a professor at Michigan State University and oversees the histology and immunochemistry laboratory of the diagnostic lab at Michigan State Uni. I'm sure you know his name, so he's an internationally renowned speaker and has won numerous lecturer awards, as well as has published numerous book chapters in veterinary and comparative pathology. And he's consulting with ANTEC Asia pathology team for, I think it's more than 6 years, Matty, but maybe you confirm, it's been a while. And we're spoiled to have you. Yeah, I think so. So we're spoiled to have you as part of the team and with us tonight, your morning for this session. So Dr. Cooper tonight will refresh us on the right practice for surgical pathology, covering everything from how to submit a biopsy sample to what to expect from the histopathology report, how to read it, etc. So I shall no longer keep you waiting. You just keep in mind that actually we'll be able to, with Anna and Afisha, relay all your questions at the end of the presentations. So feel free to shoot your comments, questions, whatever you want to discuss afterwards into the Q&A or the chat session of the webinar setup, right? And we'll relay this at the end of the presentation. So this said, Matty, the floor is yours. Thanks a lot for being with us.
Thank you very much, Myriam. Good evening, everyone. And I hope that you will find what I'm going to present to you interesting. And so we want to talk a little bit about surgical pathology, and in particular, how to submit the biopsies, what to expect from the biopsy reports, and how to interpret the biopsy report. So all of the things that you do routinely, and that might be really helpful for you, especially when you are engaging in the future now with the ANTEC services. So what are the things we are going to talk about? We will talk about some of the things which are very obvious, and hopefully you know them, and that will make it very easy. We will talk maybe about some of the things that might always have been confusing to you, and hopefully I can clarify some of them. And we will talk about maybe a few secrets that you haven't heard about it. That would be great. But again, as more of these things I'm going to talk about, you know, as better it is, because that means you already doing a lot of things routinely at a high quality, and that's what we're all striving for. So why do we even take a biopsy? And since I am German, as you can hear on my accent, I have to give you a quote from one of the first actually surgical pathologists in human medicine, Karl Gerhardt from 1873, where he said, ohne Diagnostik keine vernünftige Therapie, erst untersuchen, dann urteilen, dann helfen. Which in English translate means, without a diagnosis, there can't be a sensible therapy. First examine, then evaluate, then treat. So this is really what it's about. We want to have an accurate diagnosis. And that's usually the number one driver why you submit a biopsy. However, depending on the type of biopsy, you may also want to understand better the extent of the lesion. And what really becomes important when we talk about tumors, you usually want a prognostic evaluation. That entails often a microscopic characterization of the lesion, including particular mitotic count and grading, but also some other parameters. And then, not to be underestimated, in many cases, you really want to have a consultation with a pathologist. And I will expand on that a little bit later. So when do you even submit a biopsy? When would there be a surgical removed mass submitted for histopathology? For that, I give you another quote. And this quote is actually from an extremely well-known surgical oncologist, a veterinary surgical oncologist, who said, "I never give my clients the option not to submit a surgical removed mass for histopathology." And then he continued and said, "I don't ask them whether they want their cat sutured after a hysterectomy either." So the bottom line is there's no reason whatsoever not to submit a tissue that you surgically removed for histopathological examination. I think in many places I work, at least with most of the oncologists, this is already built into their regular fee for doing a surgery, because the case you decide not to submit for whatever reason usually comes back and will bite you because you thought it as a lipoma and it was a mast cell tumor. So you do not want to do that. I deal a lot with practitioners which come from very rural areas as well, where money is a major constraint, where some of the clients really want or can't afford to pay the extra fee for a biopsy. Even in these cases, the recommendation is at least save the tissue, save it in a formalin fixed container, and submit it if you have to 2 or 3 weeks later. If there's recurrence of the mass, the client will thank you for that. Is that ideal to do it? No, because a long formalin fixation will prevent you from doing additional testing such as immunohistochemistry, etc. But it's better than having nothing. So again, you want to submit a surgically removed tissue. If you go through all of the effort and you're doing the surgery, you want to have evaluation of whatever you removed. How long should you wait before removing a tumor? And with that, I want to give you a little bit of a kinetic background, which you probably have. When you think about it, a normal cell, give or take, is roughly 10 micrometer in diameter, right? So if we assume, which is pretty accurate actually for many processes, that it will take 1 day for a cell to duplicate after we having now malignant transformation and have a neoplastic clone, it will take 30 doublings to essentially reach 10 to the 9 cells. This would be roughly the size of a tumor of 1 gram or 1 cubic millimeter. So we're just reaching the level of diagnostic ability to recognize such a tumor. But then when you go from there, it takes only 10 more doublings, because we're on a logarithmically expanding mass, that we have suddenly 10 to the 12 cells, which weigh already a kilogram, which is in most cases not compatible with normal life. So when we look at that, it's that logarithmic curve. While that logarithmic curve is very slow at the beginning, it then shows a faster and faster tumor growth, which again, we approximately detecting the neoplasm at the level of 10 to the 9 cells. So by that time, that neoplasm has already passed through a lot of stages in its life. There's a lot of heterogeneity already developed, additional mutations. So that means as long as you wait, you're reaching a curve which brings you potentially closer and closer to the death of your patient. It also means when we treat, for instance, with a chemotherapeutic drug, and let's say we have a highly successful drug which will kill 99.99% of neoplastic cells, and you start treating right at the point of diagnostic detectability, so we only lower our 10 to the 9 cells to 10 to the 5 cells, which, using the model I just gave you, that there is approximately a 1 day for duplicating these cells. That only bought you 2 weeks. and you will be back exactly at 10 to the 9 cells. So that's why many of the typical chemotherapeutic protocols are repetitive protocols to, again, reduce the numbers repeatedly and repeatedly. But what we often then have is we have a reduction of number, new logarithmic growth, reduction of number, new logarithmic growth, and at the same time acquiring resistance until we just have a delayed growth, which might still ultimately lead, for many drugs at least, to the death of the patient. So if you have the option of surgical removal, complete removal, that's what you want to do. And again, you want to have an accurate diagnosis and prognosis. So how should you submit a biopsy? Probably the most important thing is that without a complete history, a biopsy is incomplete. And you really put the pathologist at a disadvantage, and it may really lack meaning to the pathologist. You don't want to test the pathologist by not giving a history. I heard arguments like that. Well, we want to see how good the pathologist is by not telling him or her everything. And well, that's not the point. You want to get the best information possible from the pathologist. So you want to give them as much clinical information in a condensed form as possible. It isn't helpful to attach, 30 or 40 pages of the last 5 years of clinical history, but you want to give a nice summary of the current clinical situation and then also your opinion on it. So there's the factual findings as well as, very importantly, your opinion. You do not want to just submit the mass and say, this is an osteosarcoma, because if you are wrong, then I don't know what drove you to that diagnosis. So give me the clinical parameters that led you to it, and then give me then your differential diagnosis or your primary differentials or multiple of them. You do not want to freeze, crush, or squeeze the sample when you submit it. And if it falls apart, which happens more commonly than we think, then make sure you submit all of the fragments from that mass. You want to place it immediately into a formalin. Don't let it sit on the surgery table under, the lamps, especially if it's warm or hot area. And having a tumor sitting out there for a couple of hours might really impact the viability of the cells. And you want to have a sample where you have a ratio of formalin to the sample in the container of 10 to 1. So that's very important. If you use a smaller amount of formalin, fixation will not be as good. So make sure that at least for the first couple of hours, you have the 10 to 1 ratio. If it's a very large sample, we can talk about abilities to ship without having that huge amount of fluid because simply of weight. But again, for the actual fixation, you want it at a 10 to 1 ratio. I don't think winter is a major issue to most of you. It is in states, for instance, like Michigan, that we actually go below freezing temperatures, which even with a transport sitting in a car, like in a postal service, it might result in the sample getting exposed to sub-zero temperatures. And so for this time of the year, because you do not want to have a frozen sample, even if it's already partially formalin fixed, we actually recommend adding 10% of isopropyl rubbing alcohol to the formalin. That will really significantly lower the freezing point, and it will prevent freezing, and it will have no impact on the fixation of the tissue. And then you want to ink the margins if you really want to have accurate margin evaluation. And I will talk about that in more detail soon. So select the right container. Make sure that you identify the container, not just the lids, because it can create problems, especially if there are multiple containers of similar size and shape. Make sure that the containers don't leak. That's a problem in both with the couriers as well as when it arrives at the lab. So you want to avoid any type of breakable containers. Any type of plastic is usually far superior than having glass, and it's lighter too. You want to use containers with a wide opening, because remember, after you fix your sample, it will become much more firm. So something that might have easily been pushed through a narrow opening might not as easily come out anymore after it has been formalin fixed. So containers, as you see to the right side, are ideal where the opening is as big as the circumference of the, as the width of the container. You want to avoid packaging any formalin containers with non-formalin fixed material, fresh material, or even cytology. If you have to do that, make sure you at least double bag the formalin container in like a sealed bag, because there will be some foams emerging from the container and will have a negative impact on your other tissue and even on cytology. And I will show you that in a second as well. And then make sure you always include the submittal form and make sure it doesn't get drenched and it stays clean and becomes as readable as it. So these are a couple of examples of things I've seen over the years as true submissions. As I pointed out, you know, somebody squeezed the tissue, that container. Obviously, there was no 10-to-1 ratio. And the only way to get it out, you actually had to cut open the bottom of it to even get the tissue out of the container. And yes, I have seen like that, a whole hedgehog being put, you know, into a container, or a mouse actually squeezed into a tube. I can tell you both of these were not well fixed, and it wasn't great for histopathological examination. So when you submit something to it, I want you to think for a second of how, again, we as pathologists deal with the sample we get. So if the submission just says mass, well, that's not the best history we can get. Miriam can probably tell you from recent experience that we had a case, there had been numerous opinions which varied between tumor to reparative tissue, and where, because it was a very important case, where the veterinarian actually contacted Miriam and said whether I would be willing to do a second opinion totally blind. And I didn't even know that the case I got then was that case, which was that special case. And so when I reviewed it, I sent back a message immediately saying, look, this is bone tissue, which is highly dynamic. So I need A, B, C, D to make the right diagnosis. I can tell you which direction that goes, and it's not neoplastic. In this case, that was already the answer he kind of wanted. But as you can see, I couldn't make a real final diagnosis, which I did later after I got some of these other informations based on that small sample I received. Because again, there would have been too many options, and you don't want to do that. You want to really provide the proper information that allows the pathologist to give you the best answer and don't make it into a guessing game. You know, as I said, this is really your primary responsibility, and writing a detailed history, I know, is a pain. None of us likes to do that. But if you don't do it, then really you put us at a disadvantage, and you make it much more challenging for the pathologist to interpret your case. So what should be included in such a history? Obviously, signalement, so age, breed, sex. The history, as we talked about it, the previous treatment, the diagnosis, response. It makes a huge difference whether you submit a lymph node to us, which has, from an animal which has been treated the last, 2 or 3 weeks with high dose of steroids, versus not. So again, some of these things have a major impact on what you expect to see histologically. And if I find, a lymphoid cell population uniformly populating that lymph node in an animal which has been on high dose of steroids for a while, it's a completely different diagnosis than I might have without the treatment. So we also want to know a little bit about if it's a tumor or the mass, what was the appearance, the size, where was it localized, what was the growth, the duration and the speed, which is really important. Is it invasive based on your clinical examination? Is it ulcerated, etc.? So these are all informations that should be provided. We all understand if it's just a small wart-like growth in the skin, and you submit it and make exactly that sentence, and you tell me where, and then you point out that you suspect this is a sebaceous hyperplasia, I think you don't need to give me much more. But if you suspect in particular that this is a more aggressive lesion, then getting some more information is really helpful, because it might really impact the diagnosis. You want to tell me what type of biopsy you submitted, whether it's incisional or excisional, because I will not even give you margins in an incisional biopsy. That will be in the report. If you show that to your client, you don't want me to tell you that neoplastic cells extend to the examined section margins if this was incisional. If I don't know that on some of these biopsies, it's really hard to tell. So I really need to have that information. If you want margins evaluated, which we do routinely to some degree, and I will explain what I mean by that in a second, then make sure that you identify them properly, and you can do that through different colors. But even from an orientational perspective, it is really good to place things like sutures are the best. Some people use staples, which the technicians don't like that much because you have to take them out to trimming. But sutures are really the best way. So what I mean by that is I can't tell when I have a skin mask that has been formalin fixed, which side is lateral, which side is medial, which side is cranial, and which one is caudal. So placing one suture in one of the sides and placing maybe two sutures on the lateral side, and then writing that into the description will make things very, very easy for both the technician as well as the pathologist to identify. If there's any relevant clinical work done, then please share it, whether it's blood work, imaging findings. Imaging findings can be very helpful, in particular if we talk about bone mass or space-occupying lesions affecting the skull or any other organs. That's very helpful. And your clinical impression. Again, you are the veterinarian treating that animal, so I want to hear what you think about it. So give me your final differential diagnosis and your impression overall, what you think this is. When we deal with tumors, there are obviously different types. There are small, well-circumscribed, easy removable masses with sharply demarcated margins where you can easily get clean surgical margins. Such you see it here on a right, the hemangioma, histiocytoma in the middle, or like a sebaceous hyperplasia on the left. But then you have other masses where then it even becomes an issue. Can you remove the whole tumor, or are you only sending us incisional biopsies, or do you do debulking, etc., like the mast cell tumor on the left, or the osteosarcoma on the right, or on the bottom, this episiotropic T-cell lymphoma mycosis fungoides. So what are the different samples you can submit? You can go for fine needle aspirate. The advantage with that is that it's non-invasive and inexpensive, relatively non-invasive and inexpensive. It's of relatively low risk. It can be quickly done. You get great cell detail if you do it right, and you can do it in the clinic. And the disadvantages, you have little to no architecture on it. The sample quality might vary, and when we talk about that in a second, it might not be representative of the lesion because you might have missed the primary lesion on it, and you have limited amount of sample should you require extra testing. And as you can see in this graphic here to the left bottom, it's really a major issue whether your fine needle aspirate will hit the target. Meaning, do you hit the necrotic center of a mass? Do you hit the mass at all? And are the cells that you see really representative of the primary process? How do you obtain such a sample? You do it by fine needle. You can also do scraps, imprint, swabs, depending on the type of lesion and what you decide to do. The goal is always the same. You want to have a representative sample. You want to ideally produce a monolayer of intact cells. And you want to learn something about the lesion which guides your next step in clinical decision making. So how do you prepare your slide? You lay them out in an adjacent location. You make sure that they are clean. If needed, wipe them with alcohol. If they come fresh out of the box, great. And then have utensils ready to mark and different location samples. It's often advantageous to pre-label your slides. In particular, if you take aspirates from different sites or you have different lesions, mixing up slides afterwards will ruin all of the hard work you just did. So accurate labeling of slides, I can't overemphasize that enough, is a major component of it. Usually you use a fine needle like a 22 gauge, and you can do it with or without a syringe. And then, through redirection and a forward cutting motion, you take your sample. So as you can see it here, and again, it's really up to you what you prefer, to only use the needle or the syringe. You obviously don't suck the material into the syringe. And then you carefully spread a thin film on your slide so that you create that monolayer. You don't want to create something like that, which looks like somebody has sneezed on a slide. You really want to have a nice, smooth monolayer so that the cells, when you look at them, look like these fried eggs, sunny sides open, and not like scrambled eggs, because we can't interpret that. So if you use other methods like scrapings, etc., then work yourself in from the outside to the inside of the lesion. If the surface is ulcerated or there's discharging material, you might try an imprint. You may have to remove the superficial layer, like if there's any cerocellular crusting on it, and then imprint to get the real lesion on it. If you do not clean it first, remember, you might have a lot of superficial contamination on it. So there's a pro and con, and you might do both of it. Take one with a exudate attached, and then carefully clean it, and take another one. Again, that depends on what is the primary process and what type of lesion you expect. And as you can see it right here, so palpation and potentially ultrasound might become really important for some of the lesions or other imaging techniques. You need to think of the density of the tissue and what evidence do you have, how organized that particular tissue is. So really plan your attack carefully prior to even get started, and then keep track of the different slides, as I mentioned to you before. It's not that uncommon that you may miss the target. So you go for a lymph node, instead you get a salivary gland, or you get adipose tissue rather than the mass. So this can happen, and particularly if the differential is lipoma versus something else, that makes it obviously difficult. That is one of the disadvantages of a needle aspirate. After now you have your slides, again, make sure they're properly labeled. I emphasize that again. You let them air dry. It doesn't require any fixation. You want to keep them protected while you're doing that, so that there's no particulate material falling on it, that there's no dusty environment, that you have no insects getting to them. You want to do that at room temperature. Don't put it into a refrigerator. You will get cell lysis or water condensation. And as I said before, you want to keep it away from formalin. So, the station where you do these things should not be the same where you handle formalin containers. And then you run your slides through, most people have something like DiffQuick, through your different solution. And you may have to increase the number of dips if the tissue is a little bit thick. And then you want to always stain one of your slides and to evaluate it to know whether you were successful in the process. So the other ones you just leave air dried and you submit to the clinical pathologist, and they will use a different staining protocol for that. And we will talk about that in a second. But you need to have one slide that you want to evaluate that has two advantages. You know whether you were successful, you know how good the quality is of the cells that you collected. And in the process, you can also slowly build your own repertoire and training, because when you get the results back from the clinical pathologist, you can compare to your own impressions, and you will get yourself better and better in doing that. So if the staining the first time isn't great, you can just repeat it. There's no need to repeat the whole process. You just repeat the staining of whatever solution didn't give you strong enough, either eosinophilic, well, it's not eosinophilic, pink or blue staining. When you examine the slide, so you should have a decent quality microscope, then make sure you don't put it immediately under oil. The primary purpose is to make sure that you got a representative sample and that the cells are intact, and so that you can actually do the histopathology. So you want to see whether there are too many or too few cells, whether there's too much blood on it, whether the sample wasn't spread well, all of the things we already talked about it, and whether you have to potentially restain it because your staining wasn't strong enough. As I said, normally in a practice, people use DiffQuick, while specialized clinical pathology labs usually use right stains or some modifications of it. These are more differentiating stains. They allow you to see, for instance, chromatography granules much better. So it's much easier, for instance, to recognize a mast cell tumor, even in a high-grade, poorly differentiated mast cell tumor. So again, that's the reason why you don't want to stain all of your slides, but only stain the one that you evaluate. And you can decide whether you keep that slide or you send it as well with a shipment to the clinical pathologist. But make sure that the clinical pathologist get a series of high-quality unstained slides that are properly labeled. As I pointed out before, if you put the slides in the refrigerator, you might get lysis, as you can see here, of the nuclei, or here on the right side, as you see on some avian red blood cells, the lower portion was exposed in a package was shipped together with numerous formalin containers, which were not further put into protective plastic bags or something like that. And as a result, you got massive shrinking and artifact through the formalin, just vapors which were created while the slides were in the same package. You went through all of that trouble to create your slides and get them sent to the laboratory, and then they might get damaged. So protecting your slides is a major part. There are a lot of different commercially available protective, very often very cheap packaging alternatives. So again, use any of these, but make sure you protect your slides so that nothing like what you see on the right side can happen. So the next thing after that, you can do punch or TrueCut biopsies. With that, you have the advantage that you get more tissue and architecture. It's still a small sample, which may still be difficult to diagnose. You have to understand that. You don't get the same cell detail because now we're talking about formalin fixation, which results in shrinkage of the cells. And it still requires more processing time because now we're talking about not only the fixation of formalin, which is on average 24 hours, but when you ship it to the lab, it will be by that time fixed. But then you still need the tissue processing, so running it through, the ascending alkaline to get the water out of the tissue, and then putting the wax in it, and then get the water out of the tissue. So we're talking by the time you actually have slides cut, another 48 hours before the slide can be read. So you're adding, with the pathologist interpretation, 3 days at least of additional handling to it, which is obviously a big difference to looking straight at a fine needle aspirate. You also have the problem that with a TrueCut, you can create squish artifacts. And as you see in these pictures, and the streaming here, these are nuclei which essentially got squished by taking that sample. And as a pathologist, it essentially becomes impossible to tell what cell types these are. So in this case, I'm giving you one example. We actually use just vimentin and cytokeratin. And you can see that even though the sample was severely squished, that some of these nests still contained epithelial cells, so that this really probably was from a carcinoma with a tremendous desmoplastic response. So at least you could make a suspect diagnosis of it. But again, it was completely, and the low magnification kind of looks like it, but it was impossible to confirm that on higher magnification what these cells really are. So you have to be aware of it, and you want to try to avoid things like squish artifacts, which can be sometimes very difficult. The size and the depth of your incisional biopsy is very, very important. Unfortunately, we get some which are not deep enough, and you only get the surface, or you're going, for instance, for a liver, and all I get is some muscle in it. The number of samples is very important. So as larger the lesion, as more samples you want to take. So usually 3 to 5 is kind of the average there. The appearance of the mass plays a big role on how you take your samples. So if it's a soft tissue mass, in general, you want to go for the periphery. So you want to have the area where the neoplastic cells enter into the surrounding healthy tissue. If it's a bone lesion, you want to do the opposite. Whereas in a soft tissue mass, often the center is necrotic. In a bone lesion, if you go to the edges, you usually have highly dynamic bone, and you have a paracortical proliferation to compensate for bone loss. So you really want to go to the center of the lesion, which is pretty frightening if you have a small dog which has a severely lytic lesion, and you have to go in the center of it, that you don't create some major fractures. I can tell you, to me, some of these bone biopsies are the most challenging. I think I have a pretty good grasp on how to do them. I would be scared to do it in some of the dogs. I can tell you from experience too that one of the surgical oncologists I worked with for years, I would say 95% of her bone biopsies, I get a solid diagnosis. If I get bone biopsies from practitioners which do it maybe once every couple of months, often the diagnostic capability drops to under 50%. So this is, for instance, something where you might consider sending the animal to a specialist, depending on the type of lesion you have, and how comfortable you feel to do that. You have to consider whether there's a risk of spreading a lesion. You also want to think about the healing process afterwards. So again, for some of the neoplasms, transitional cell carcinomas, for instance, there's a risk of potentially spreading and causing carcinomatosis. So think ahead what your definite therapy is and coordinate that together with the type of sample you do. So again, plan your attack correctly and not only think of getting the sample, but also what you want to do afterwards and what your goals are. So is it surgery, radiation therapy? So what are the things that are planned afterwards? Why is the type of the biopsy so important? This, for instance, from a paper on soft tissue sarcomas, where people tried to see how accurately the grade of a soft tissue sarcoma was determined using an incisional biopsy. And so soft tissue sarcomas are one of the neoplasms where, for instance, small incisional biopsies are not very helpful to get the accurate grade. So as you can see, the concordance with grade was only 59%, so a little bit more than half. And 29% of the pre-treatment biopsies underestimate the grades and 12% overestimated. That is also exacerbated by the problem that the grading for soft tissue sarcomas is not only based on mitotic count and cell differentiation, but also on the degree of necrosis, which is really not ideal in a grading system at all, but it has a major impact. So you really need to have almost an excisional biopsy to get pretty much accurate grading for soft tissue sarcoma. So submit all what was removed and blocked, as we already talked about it. Submit it with the normal tissue margins if you want us to evaluate these margins properly. If it's a really big mass and you think about it, penetration of formalin is roughly 1 centimeter within an hour. So you want to expedite that process. So what you can do is you can do transverse incision into a big lesion within 2 centimeter distances. You don't want to cut it completely through, because then you lose the orientation and you lose the architecture. But as you can see it here on the left, so you want to place a couple of these cuts, kind of bread loafing it partially, and that will allow nicer penetration. But you only do that if you have large solid tumors. Another tissue where you may want to do it are large spleens, but often they are relatively thin. So if the amount of formalin you have is large enough, then they fix usually quite well. Or they fix at least well enough from the outside in that you can make afterwards a good histological diagnosis. If you have, for instance, a very large spleen or an amputated leg, and you don't know how to submit it in a large amount of formalin because the container would become too big or the weight simply becomes prohibitive for shipping, what you can do is you can fix the tissue for 2 days in formalin in your practice, and then you remove the leg and you remove the very large spleen, and you just wrap it in some paper towel which is drenched in formalin, and you put it in a plastic bag and you double bag it and seal it, and then you ship it like that. So a tissue, after it has been fixed for that period of time in formalin and staying slightly moist with formalin, this works exceedingly well. And so we get tissues shipped sometimes with 2 or 3 days shipment, and we never had a problem with that. So you can do it that way, and you can submit even a whole leg. We always prefer to get the whole spleen. Getting portions or small samples of spleen is really, really difficult sometimes to interpret. And so sending the whole spleen, especially from a larger animal, is really important. Fixation can be a problem in some of these denser tissues, like lymph nodes or spleen, which have a dense infiltrate of like lymphocytes. And as you can see, we have good fixation on the first couple of centimeters, and then the lower tissue essentially is autolyzed, and that's how it looks like. So interpretation becomes very, very difficult. Interestingly, even at that stage, you go to the outside, you can still see enough of the morphology of the cells to make a diagnosis. And again, even on the outside, your immunohistochemistry will be good enough to get that diagnosis. So fixation is an important part. And again, if you have to, then place some some penetration cuts in it, that will happen. Decalcification is another major impact factor on a biopsy. When we decalcify tissue, we limit ourselves in what type of add-on testing, whether it's immunohistochemistry or other molecular testing we can do. There are a lot of different methods for decalcification. Some of the ones which are most gentle simply take too long, like EDTA. We're talking about weeks rather than days. So all of the rapid decalcification media, they have a negative impact on the cells themselves and on the molecular integrity of these cells. What we do routinely, and I wanted to show you that for some of the tissues like a toe, we will always do the routine sectioning of the soft tissue first, and we will examine that. And we also look at the same time at the routine proximal margins. And then we will decal it afterwards, and we will do the proximal margins as a decal, and we will also cut the longitudinals to the whole length of the toe to see whether or not the tumor directly impacted, or the lesion, whatever it was, directly impacted the underlying phalanges. So that's the routine procedure we have for our trimming techniques. If you're interested in that, we are happy to share that. That's actually one of the strengths we have to offer, that we have very strict trimming protocols. So every tissue gets trimmed every time the same way, and the pathologist will actually tell you how that tissue has been trimmed so that you get a better understanding. I have seen a lot of reports from a lot of services. I can tell you this is not routine, not even in human medicine. So, but it makes a huge difference, and a lot of the specialty oncology clinics really appreciate this. As you can see, when we take, for instance, and I mentioned that before, punch biopsies from, like this case, in osteosarcoma, and we stay with the edge, all what we had here is periosteal reparative or compensatory bone growth. And that's what I would see histologically, which gives me nothing. But you have to go for the center where you see the neoplastic cells, in this case, even producing osteoid, so getting an accurate diagnosis. So the last one is then the excisional biopsy, which gives you the huge advantage that you have complete architecture, you can assess the margins, you can assess the growth pattern. So from a diagnostic perspective, that's a really, really strong plus. You have plenty of tissue normally for additional special stains or molecular testing, etc. So you get usually the most reliable diagnosis with an excisional biopsy, and you get much more accurate prognosis because you can more accurately determine the mitotic count, the grading, based on the areas of highest aggressiveness that you observe within these sections. You have, in contrast to cytology, less cell detail. There's no question about it. As I mentioned already before, you have more processing time, but that's true for the punch or two cuts as well. The fixation might be negative for some of the antigens. I think that was a statement probably true more 20 years ago. In today's world, most of our protocols have actually been adjusted to deal with that. So decalcification is still a problem, but for regular formalin fixation, 24 to 48 hour fixation has no impact on the molecular testing we are doing. Another major component is that the surgical cost and the risk of the surgical procedure are actually going up as well. And there might be then also, depending on the size of the sample, some problems with handling it, but that's usually easy to overcome. So in an ideal world, you can see when you compare to the previous one, which is a little bit of out of focus, we actually have both. We have full cell detail and architecture, and how do we achieve it? We're running in parallel, first the cytology, and then we do, based on the information we get from the cytology, we're doing the full excisional biopsy, which then not only has the purpose of accurately determining or confirming the diagnosis, or determining it in some cases, confirming the margins, and then also thereby accurately prognosticating a neoplastic process. So you can see on the right side how much easier it is to recognize cell details on the cytology, while you get much more shrinkage on the formalin fixed sample. But in contrast, you get the tissue architecture, which tells you the destructive lesion in this osteosarcoma in invading, destroying bone and forming osteoid. So it makes diagnosis much, much easier than what you could have done on the cytology. So just summary what we are going to submit. As larger the lesion, as more numerous biopsies you should take. If it's ulcerated or necrotic, sample the edge. We want to see the transition zone between normal and diseased tissue. Take the sample deep enough to assess the relationship between the tumor and the stroma and to really get us a tumor. Submit the margins identified with a number of different sutures. So maybe one suture on the cranial margins and two on the lateral one, something like that. And if there's a draining lymph node that you decide to remove it, always submit it as well. Let's talk a little bit about how we identify now margins. You do that by inking. You can buy actually some of these commercial kits, as you see on the right side, if you really want to be Picasso and you can create beautiful artwork with that. You can just go into some cheap departmental store and then buy some waterproof ink. You know, in the US, like in a Walmart, black is always the best. Yes, you can use a lot of different colors, but as I show you in a second in the picture, black is the easiest one to read. If you want to have 2 or 3 different colors, stay with the darker colors. Things like yellow or like light orange can be really sometimes struggling. So darker colors are always easier to read. What you essentially do is you take your tissue, you let it air dry for a few minutes, that it's not completely wet, and then you take a cotton top or some gauze sponge, and you put your ink on it, and you carefully put it on top of the margin. You don't want to drench it, that it gets deep into the tissue, but you really just blot it over the edge of the tissue. For the lateral margins, having like a Q-tip and rolling it along works quite well as well. And as you can see here, for the show effect, 2 different inks were used to help you identify cranial and caudal margins. Again, this can be as easily done by just placing sutures in it. So one ink is usually enough. If you have multiple ones, you can identify specific margins. If there's only one margin you are interested, that's why it's advantageous you do it yourself. You can only ink that area. So again, you know what else you remove for tissue. So these are all things you can do. And so after we get it, we fix it. As you can see, the ink is well preserved. This is well done because the ink didn't penetrate into the tissue at all. You trim your sections. You can see the ink right along the edge of the slide. And then when I look at the histology, I can see that the deep margins are nicely black ink. And now you understand why I'm saying it's so much easier to read black, because as you can see, if you have some of these lighter colors, they might be much harder to pick up. So summary for clinician's responsibility: provide a complete history and signalement. I can't overemphasize that enough. Do not freeze, crush, or squeeze the sample. Adequately label the sample. Submit all fragment if the mass falls apart. Make sure you have an adequate volume of fixative. So 1:10 is the ratio from tissue to fixative. Ink the margins for evaluation. And then one of the things is be prepared that there might be additional charges if this is a complicated lesion. So kind of sensitize your client to it. We will promise you that we will never, ever add on charges just to make money out of it. I will be actually the first one to tell you that I wouldn't do a certain particular test. And clients I've worked with years for, they will actually attest to that. So we will guide you, but if we tell you that we recommend certain testing, it is because we are limited on what we can do on the histology alone. So just again, potentially sensitize your clients to it, that might always be an issue or a possibility, and I can't tell you upfront. So you want to kind of manage the expectations of the client. When you get the biopsy report, now what happens next? First, you want to make sure that this is a correct report for the correct patient. Name and owner are correct before you even call the client. Mistakes happen. They can happen at every level. So make sure before you communicate with the client that what you have in hands is really what you should have in hands. Make sure that the signalement is correct. If not, call us. Whenever there's a major issue, whenever there's a problem, whenever there's a question, we really encourage that, or text us or email us, whatever the options are, but please communicate with us. So we really like communication. You can do it for certain things directly with a pathologist. You know, our emails are right underneath the biopsy report, or you can do it with a lab. And make sure that the tissue is correct. If not, call the pathologist. So as an example, you submit a mass from 11-month-old golden retriever from the right front foot, and then you get a report and it says it's an 11-year-old golden retriever. And so, you know, this was a histiocytoma, which is usually seen in younger dogs. And then you get already the statement from the pathologist in dogs older than 6 years, as in this case, cutaneous lymphoma is a primary differential, and they recommend additional IHC to rule out a T-cell lymphoma. If the pathologist would have correctly identified it as an 11-month-old dog, and I don't know in this example whether there was a typo done on the submittal form or whether there was a typo done when entering the submittal form into the electronic system, or the pathologist didn't read it properly. So I don't know at what level there was that miscommunication, and it doesn't really matter. But the problem is, as a pathologist saw it as an 11-year-old dog, a recommendation had to be made to differentiate the histiocytoma from a cutaneous T-cell lymphoma, an episiotropic T-cell lymphoma, which is really important. If the pathologist would have seen that it's a dog younger than a year, that second portion of the comment would have been completely different, just saying that this is most consistent with the histiocytoma. If you want proof of or confirmation by molecular testing, you can do it, or you could do it even if the mass recurs, which wouldn't be expected 3 months or 6 months later. We would always save the tissue, so we could do that additional testing 3 months or 6 months later, no problem. But I would have not recommended to immediately do that confirmatory testing if I had a clear-cut diagnosis of a cutaneous histiocytoma in an 11-month-old dog. I would have recommended it in an 11-year-old dog. You want to know how the specimen was trimmed. This is really important to understand your margins, and I will talk about that in a second. So you want to know what type of sections have been examined. So let's look at examples. Most laboratories, they use the radial method. So 1 section to the short axis of submitted specimen and 2 sections perpendicular to the axis. In some labs, they actually only use 1 representative section. That doesn't give you much of an impression of the margins. If you think of a section, and let me show you that in a picture in a second, of the tumor being perfectly symmetric, well, that's fine, but in the real world, that's usually not the way it works. If you have small specimens, they are usually bisected. And then if it's a really huge mass, then we usually only take, and everyone does it the same way, only representative section, which 1 coming from the surface, 1 from the deep, and 1 from the narrowest lateral margin. So to just better see or visualize what I'm talking about, if we go for the radial method, again, we're cutting through the mass cross and half sections. However, in most tissues, these masses are not as perfectly circular as this. So the first section goes through the mass, and based on palpation, we identify the narrowest lateral margin, and that's where we place it through. And that's what you would see if the mass is small enough to fit on a single slide. If not, then you might get 2 slides or 3 slides with that being split. And if it gets bigger, then we do the representative sections as we talked about. The second cross sections then going to the perpendicular margins. So that's what you would see on the second slide. So if we do margin evaluations on a regular biopsy, we will only measure the narrowest margin on these 4 sections, which means more than 90% of these margins have not been evaluated, which again doesn't matter if the mass is perfectly circumferential and behaves like we expect on palpation. However, most masses look more like that within the tissue. So when you place these half and quarter sections, there's a huge risk that tumor may escape on one of these margins that we never looked at. So you would get a clean margin on this or this section, because that's all what has been looked at. And, you know, the tumor escapes or reaches the margin in another section. Therefore, there are other methods to better look at that. You can do parallel slicing or bread loafing or pizza pie slicing. And what we actually do is we do in tangential section, which is like an orange peel. And that's what you're actually going to see. So in this particular mass, we had, and the yellow lines have been cut perpendicular to the section. We had actually 6 sections being cut perpendicular to the short axis, and another, 7 sections cut perpendicular to the long axis. These are your lateral tangential margins, and these areas that you see were actually what we have on the slide. So these areas correspond to what we see on the slide, and our technicians will make drawings which look exactly like that and convey that to us as a pathologist. And these are the deep margins. So this type of sectioning is done as a special margin request. And when we started that out, everyone told me, this is nuts. You can't do that. The costs are exorbitant for that. And nobody will pay for that because it might result in a bigger mass into 50, 60, 70 sections. Actually, we have some masses with more than 100 sections, which will take time to read. So what we actually do is we identify these cost for margins based on the size of the excision, not based on the tumor. So you can order that as a special add-on. We don't do that routinely, only if requested by the client. Routinely, we do, like any other lab, we do the half and quarter sections. When we started that out, I didn't expect it, but it has been one of our fastest growing submissions on the biopsy service. Almost every specialty oncology lab wants exactly that. Because even if the cost, I'm saying, is $400, if you do radiation therapy, which you have to do if you have dirty margins, you can add a 0 to that price. So this is money well worth spent to really confirm that you have complete excision. And it's the only way to do it. So you get the distance based on the half and quarter sections, and you get confirmation of clean margins based on these orange peel tangential sections. So again, another example, and the report would then even state that, you know, these are the margins we have seen within the radial sections, and then that these other sections were all clean. And so again, as I explained it before, what you see in these red boxes, actually, or black boxes, is what we saw on the slide of the lateral or the deep tangential margin. I would not recommend such complete margin evaluation for soft tissue sarcomas. They're like little octopuses, and so they have these tentacles, and they can really go along fascia, and it becomes extremely difficult in a tangential section which cuts perpendicular through such a tentacle, and to see whether you're dealing with a fascia or you're dealing with a little side arm of a tumor. So for this, actually, CT is a much better way to approach it if you really need to see it, or MRI in some cases. But again, that's one of the tumors I wouldn't recommend it. Mammary tumors, mast cell tumors, it's an ideal approach to get clean margins. Routinely, if we have tissues within a lobe, like liver or lung, we will do automatically sectioning of the margin. That's part of our service, but that only works if you submit the whole lobe and not just portions of the mass. And we will do the same if we have intestinal masses, that we routinely will cut the ORAT and up-ORAT margins, and will evaluate these, and then we cut the sections of the mass as well in the intestine, so if there's a mass effect. So that's why it's important to also identify which side is the ORAT and which side is the up-ORAT one. So if only one of these two sides is dirty, we can tell you exactly where it was, and you get a clear idea of it. If you have really small tissues, then you want to put them into little cassettes that you can get. You want to even put some foam in it that the tissue can't fall out. And there are these little plastic containers as well that you can use to prevent that the tissue falls out. If you have muscle biopsies, you want to kind of tie them. You can do that like here in this case creatively with some needles from a syringe, but you want to stretch out your muscle because during formalin fixation, it will coil together and it will look something like that. And you really want to see the normal morphology. For lymph node sections, so if you submit a mast cell tumor together with a lymph node and the report says the lymph node did not contain evidence of neoplastic mast cells, your first question should be, how was that node trimmed? How many sections were examined? And were there special stains used to examine the node? Why is that the case? I'm giving you an example. If you just take a node and you place a single section or one representative section through the node, depending where you place that section, it can be completely clean. And so I'm just in red have drawn here different tumors, some of them being very small. And as you can see, section C alone would have been completely clean. So you really need to section lymph nodes like a bread loaf multiple times. In human medicine, that sectioning is done at 2 millimeter intervals routinely. For that reason, we actually offer a lymph node panel because, again, costs go up. So otherwise, we will just look at representative sections. And then you should stain these with either toluidine blue or Gimsa because you really want to see the granules, and then you can properly assess whether we're dealing with an HN1, HN3, or HN2 type metastatic spread of a mast cell tumor to the node. So what do you expect from the cytology report? First, you want to have useful interpretations from useful samples. So there should be enough information to guide your next step. Ideally, you want to know at least whether it's inflammatory versus proliferative versus something else. And if it's proliferative, in the best case scenario, you get a specific diagnosis, like for mast cell tumors, or a general cell type, like a round cell tumor, or you only get differential diagnosis. But even that guides your next step. And then you want to know whether there's presence or absence of malignant features. You always want to integrate the microscopic findings into a meaningful interpretation. So when we talk about the biopsy report, the extent of the lesions, the margins, is there an accurate final diagnosis, and then again, the prognostic evaluation. So ultimately, the purpose of the report is that we bridge the gap between the beginning of the disease and its end stages. So there's obviously some speculation in it based on what we know about the process and how a certain tumor, for instance, normally behaves. So for some cases, it's necessary that there's some follow-up so that there is communication with the pathologist, because again, we kind of try to predict what the end stage of the disease will be based on the snapshot of the lesion we're seeing at a certain time. So the best outcome is you get a fast, accurate diagnosis of a specific tumor entity if we stay with tumors or whatever the diagnostic entity is. You get an accurate prognosis, which leads to a targeted therapy, and then you and your owner are both happy. The worst outcome is you get no diagnosis, which will happen, and which makes you feel like you wasted your money, time, and labor. The therapy is delayed or ineffective, and not only you and the owner, but the pathologist are equally frustrated because they couldn't help either and spend their time without giving you an answer. And then there's a not so golden middle, which actually happens probably in a large number of cases, that you get a partial diagnosis, which often is only morphologic. So you don't have a specific tumor diagnosis, so thereby you have no prognosis, which means now you come to recommendations and you will have next steps and additional costs. What are some of the responsibilities of the pathologist when they send you the report? If it's a neoplasm and if it's malignant, and only then, they want to, or they have to give you a grade. That's mandatory. A grade is usually classically based on mitotic count, but it can be based on different factors based on the type of tumor you're dealing with, like cell differentiation, architecture, invasiveness, etc., etc. Why is a grade important? It plays a major role in the prognosis and thereby treatment choices, whether it's mammary tumors, mast cell tumors, soft tissue sarcomas. You also want to know whether there's lymphatic or vascular invasion, because that indicates a high risk of metastasis. And then you really want, regardless of whether it's grading or not, the mitotic count, because it gives you at least some indication of biological behavior. And then you want a final diagnosis. You want it with comments, and ideally you want it with references which are current and not something which is done, 50 years ago, but really something that reflects the current knowledge of the literature. What is a good report? It can be short. That's okay if all the important information is there. So don't look at the length of the report for quality. Keep in mind, if something is not present, and the report still should state if essential for diagnosis or prognosis. So as an example, if a primary differential is a melanocytic neoplasm, then the report should comment on whether or not there is junctional activity. So for sometimes you expect the pathologist to comment on negative findings. In general, we don't do that because it's a waste of time. But if it's essential for making the right diagnosis, as I gave you an example, differentiating between a soft tissue sarcoma and a melanocytic neoplasm, there should be a comment, for instance, about junctional activity. There are some nuances in the pathology report. So the neoplastic cells did not extend to the margins in the planes of sections examined histologically. Or the neoplastic cells extended to the margins in the planes of sections examined histologically. Again, that's the comment you want to see whether or not the tumor extends to the margins we examined. I don't know whether you took extra tissue. That's why it's important that you also tell me whether it's excisional or not. I will not have that comment on an incisional biopsy, and you do not want to overread that little word did or did not extend, because that makes a big difference. You do not want to see something like extend beyond the margin of the plane. We cannot evaluate beyond the margins. That tissue is still in the door. The neoplasm has not been completely excised. Again, I can't assess it as a pathologist. I can only tell you what I see on the slide. So this is not something we ever put in our reports. And again, you may have taken additional tissue to it. These are all things I don't know. So we only talk about what's actually on the slide. What do you want to look for? Is the correct tissue described? If not, call the pathologist, because there might be a miscommunication, it might be a typo, or it might be really a mix-up in tissues. So make sure that you call the pathologist. Do you have the extent and demarcation of the lesion? Is it solitary versus multifocal? What's the mitotic count for malignant tumors? And the description of the cellular features. In a benign tumor, you do not need the mitotic count. It's irrelevant. The description of the cellular features and any significant and secondary concurrent findings. How definite is the diagnosis? So there's a spectrum of confidence you will get from the pathologist. Let's say we have an oral mucosa and the diagnosis says malignant melanoma. That's a clear-cut diagnosis. Alternatively, you could have a diagnosis of a melanocytic neoplasm. That's still a good diagnosis. The difference is the pathologist can't determine whether it's malignant or not. And then you will get recommendation for a prognostic melanoma panel. However, you might get a diagnosis like suspect malignant melanoma. Why would that be the diagnosis? Because at that stage, the only indication I have of malignancy is that there is a higher number of mitotic figures. While the cutoff is relatively low between aggressive malignant melanomas versus those of low malignant behavior, I can tell you from experience that many oncologists I work with, if the mitotic count is below 40, they insist on the prognostic melanoma panel. Some are at 20, but most of them are at 40. And that's an arbitrary factor they came up with. We will give you the recommendation, and I will tell you based on that recommendation whether or not I would run the panel or whether I think it's not necessary. But it's really your decision to then make that decision. Or we only have a suspect melanocytic neoplasm. That's a much bigger problem, because now I'm not sure whether it's even melanocytic or a soft tissue sarcoma, for instance. At that stage, we would recommend a diagnostic melanoma panel to confirm whether it's a melanoma or melanocytic neoplasm, which if it is, you still might need the prognostic panel afterwards. You can get a diagnosis of just an undifferentiated malignant neoplasm, which at least you know it's malignant, but it doesn't help you to pick the right therapy. So that will require, if the client wants additional therapy, which is always the main concern from your side, you know what the client wants, what the client is willing to do next stepwise. So that will also determine whether some of these next steps should be taken. Or you get the really worst diagnosis, which say, please comment, because we really don't know what it is, or we have only certain differentials, which we will explain in the comment. So you are in trouble when you get an undifferentiated malignant neoplasm. The exact cell line could not be determined based on routine histological examination. So differentials can be wide-ranging in worst-case scenario. And so this could be anything from a carcinoma to a melanoma to an unidentified flying object. And then you might get all kinds of recommendations. Unfortunately, that's sometimes the way it is, that we can't give you an ultimate confirmatory diagnosis. Prognostic panels and molecular panels, which really have changed the way we're doing particular tumor pathology. And then comments. So again, what you look for the comments, you look for the grade, the grading scale, what the grade means, and the link to the reference, all in terms of prognosis. You look for the actual prognosis. If the diagnosis is uncertain, you look for recommendations for additional testing. And then again, recommendations for additional molecular testing for better predict the prognosis if such testing is available, or to determine targeted therapy in some cases. If you get adenomas, make sure they match with the previous report. If not, call the pathologist. Should you ask for more? There are 3 situations where you should ask for more information. If the histopath diagnosis doesn't fit your clinical presentation, something is wrong, so you need to communicate. If there's crucial information missing in the report, or, which hopefully isn't the case, that all information is present but not detailed enough. So example, if you have a benign tumor diagnosis, but the lesion presents to you as highly aggressive, there's a discrepancy. You need to communicate with a pathologist and you need to work it out with them. So this can be the result of that the sample was not diagnostic, which happens. This could be on the other side, a mix-up of the sample, which luckily in the years I've been working with Antec has rarely happened. It could be a wrong interpretation of the clinical information, or it could be an atypical presentation. In either case, call the lab, call the pathologist, communicate. So here's a good example how something can happen just based on the sample submitted. This is a histologically low-grade, biological high-grade fibrosarcoma, which the name already says. They occur in the mandible or maxilla of dogs, mainly like Goldens, Dobermans. They look histologically like fibrous connective tissue. And if I don't have the full clinical presentation and a good history, these will go out as being written out as some type of reparative lesion, some fibrosis, etc., and they will never go out as this diagnosis. And they have even metastatic potential. So again, that shows you how important that communication between you and us is. You also want to really have information about, as said, margins, grade, vascular invasion, etc. Yes, you want to know some negative findings, saying that there were no neoplastic cells observed. That's important. Otherwise, you don't want to have all of the negative findings in the report if they're irrelevant for the central information. We talked about the quantification of margins for malignant neoplasms. We will give you that automatically on the cross and half sections, but this is not as helpful as getting the full margin variations. For routine samples, that's usually what you get, and for many cases, that's totally satisfactory. We will not tell you that something has been narrowly excised or something like that, but you will actually get a picture with the actual margin as part of your biopsy report. If it's high grade, then you need to have an explanation why, and then you can can make the proper therapy plan. So don't be ever afraid to call us. You know, it's I know that there might be some hesitation. I heard that. I can promise you that most pathologists, that includes myself, actually enjoy communicating with the clients. I have a couple of the specialty veterinarians actually direct on my WhatsApp. I just got a message from one of them today. So you know, that gives me information that I get better follow-up as well. It increases my ability in the future to better understand rare cases and certain cases. So it will always be well received. I promise you that. If you get a call or something is wrong, it doesn't mean that there's lack of competence. We will always give you a second opinion if you really doubt it, and that's free. You know, obviously, we don't like to get a second opinion being asked on every second case simply for the amount of time we spend, but it's absolutely fair. And all of us get requests for some of their complicated, difficult cases where there is really a discrepancy in particular between clinic and interpretation for somebody else giving a second opinion. We actually often do that internally on our own accord, because some of these cases just require a second opinion, or you just want to hear from one of your colleagues whether you're on the right track. So this is pretty much routine. So again, difficult cases will require often group decisions. And you know, I'm actually doing some of the cases also through MSU, where I'm not doing second, but I'm doing fourth or fifth opinion on a pretty regular basis. There's no pathologist who hasn't made a misdiagnosis at some point. You know, so again, it will happen, and you will have a bad day, and you make, or something is wrong. So we all make a misdiagnosis. So don't feel bad in any way, and just contact us if something doesn't add up in your opinion. So how can we do all better? This was a study which actually kind of looked at soft tissue sarcoma reports in the US. And as you can see, only 64% had even a gross description of the specimen in there. On the other side, the actual measurements were also only in 59% of the reports. So I think both, you know, clinicians and pathologists could do better, so that these numbers need to go up. What was nice to see is that the grade was reported in 97%. This velocity classification in soft tissue sarcomas is really of no meaning, so the 50% are of very, very little meaning. So with that, I brought it to an end, and I'm happy to answer any questions.
Thanks a lot, Tamadi. That was a great presentation. Always good to be refreshed on the basics, but I mean, it's maybe in the lab, we know very well that it's not uncommon to receive, you know, lacking of history and stuff like that. So it's always so good to refresh everyone on this. It's super important. So
I see one question in the chat already. So let me respond to that one. So the question is, how long are samples held in the lab for? After we create a paraffin block, and Miriam, correct me, but I think right now we're holding these forever, right? And we haven't discarded any paraffin blocks yet, have we?
Yeah, so yeah, actually in terms of keeping the histology samples so far since we basically started the activity, we kept everything. For the idea is for research purposes eventually, or for studies, retrospective studies, etc. So we have got luxury to have space somehow. In Hong Kong it's rare, but we kept all the blocks so that it's always possible to go back if needed. Yeah.
So we can always go back to the block to add on molecular testing. So the good example would be that cutaneous histiocytoma. Let's say you have a three-year-old dog with a clear-cut cutaneous histiocytoma. I would tell you it's a cutaneous histiocytoma, and I will put in the comment that I can confirm the diagnosis with add-on molecular testing. If it would be my dog, I wouldn't spend the money, because I feel totally confident. As one of my friends in human medicine says, you know, there's a new generation of clients out there who wants for everything a molecular test. They should sometimes just listen to 30 years of experience and looking at that. But that's the way it is. So you might have an owner who will want a test regardless, because they want that peace of mind. Fine. You might have another owner who follows that. And if this really is the rare occurrence, especially that young dog, of being a T-cell lymphoma, they can mimic each other really, really well. And it comes back in 3 months. We can go back to the block and we can do the test then. So you don't even have to re-excision it. So we can do that. If it's a 6-year-old dog, I would recommend strongly confirming it, because at that point, the likelihood of being one versus the other goes up, unfortunately. So again, that's a good example and how this really is applied to it. We cannot hold the actual formalin fixed tissue that long. It's plain and simply, some of it gets used up all in cutting it into paraffin. Some of it, if you let it sit for 2 weeks, it becomes really useless for using it into the paraffin blocks. And then it's a storage issue. So Miriam, what do you think? How long do we have at the moment the formalin containers? You know, how long
usually it's 1 to 2 months. We can manage to keep it all, and then they are discarded. Yeah. So for those
right.
ones, that's
and
usually
again, it depends on how much tissue is in there. But the paraffin block, which is really what you need, we keep at the moment forever.
We got another question, Hannah.
Yes.
You want to relate? Yeah.
There was an ocular sample. There was an image saying no removal surrounding material, not sure whether to use formalin. So that varies from place to place. I think formalin actually works great for ocular samples. We are very happy with it. We do not want to trim off all of the surrounding glands, etc., and we just leave it, and we put it in sufficient amount of formalin. So the ratio is really important. Some places recommend injecting the globe with formalin. I think when we talk about dogs and cats, it's not necessary. You're doing more damage spraying the formalin in there and extending it. So most of the ocular pathologists I work with, they really just prefer the tissue, the eye taken as is, and put it in formalin.
Okay. Thank you.
There used to be special, or there are special fixatives like Boeing and others. They are not easy available in practice. It creates more trouble than it's worth it. The quality for routine samples with formalin is more than enough. So we can, and again, in today's world with the technologies we have and the molecular testing, we can pursue anything we need. So it's much better to stay with formalin, because some of these other fixatives are better off, because we don't know how they react with some of the molecular tests we have, etc.
Just wanted to remind everyone, by the way, that we provide all the lab supplies. So if you need anything, whether these are the pot, right, to collect your histo, slide holders to protect your slides, etc., just go to your SVG team, and they have the stock there. They will refill as needed, and so you can just get them directly and for free. The platform Health Track is basically allowing the supply orders. So again, ask the team for guidance on how to use that, but that's very simple and straightforward. Yeah.
Anything else? And again, if questions come up later, you can always email us. You can ask questions when the case comes up. You know, can email Miriam directly. So don't be shy. We are happy to answer any questions which come up.
Absolutely. And for the consultation, so really something I want to emphasize, because I think it's awesome. If we definitely have a whole team of board certified, so as I said, oncologists, internists, etc. So I mean, I can see in Asia that practitioners really enjoy that as soon as they get the pathology report, and if it's malignant, then they're very straightforward. They go and ask for the oncology support, and so we've got the team here to basically discuss directly with you about the case, provide guidance in terms of options for treatment, protocols, etc. So that's really, really valuable. Yeah.
And some of our consultants, they are really top-notch consultants, like Laura Marconato. I mean, she's an internationally renowned oncologist. So you know, I've worked with her for many years, publishing together. She's absolutely top-notch. So we have some really good people if you need that service. So yeah, thanks, Miriam, for bringing that up.
Yeah, give it a try. All right. Well, if no more questions, I know it's already late. It's actually super late for me, so time to wrap it up probably. But anyway, thank you so much for joining us tonight. And so looking forward to see you again on December 5. Dr. Mati will give us a second session to focus more and explain more about all the immunohistochemistry panels. So when to use them, how to interpret, and how to read those reports, etc. So that's the second part of our introductions. And so feel free also to prepare if any questions, whether related to today or anything else, or these HC panels, because it's definitely a big part as well. Yeah, looking forward to see you then. We'll send you the link, or maybe you already have shared the link, Anna and Afisha, to everyone. But and also for today's session, just quick reminder that it's been recorded. So basically, you guys will receive also every time we do a webinar sessions the replay link that you can share happily with your teams if they couldn't make it tonight. So that's really something that we also look to it. In terms of CPD points, we will work together so that you can get certificates as well for the one who could make it live. So all of this will be put in place and you can access it from now on, which is great. All right. Thank you so much. See you soon then.
Thank you very
See you in a
much.
couple of weeks.
Goodbye, everyone. Have a good evening.
Take care.
Bye-bye. Bye.